Alright, hello everyone. It's Monday and I'm very happy to see you all here. Can you hear me in the back? Yes, thank you. So I have a question. I don't have any review questions for you today because it's part 2 of the integumentary system, so I'll ask you questions as we go along to tie together what we know. But I have a couple of questions for you about the exam. Right? You all got the results. So my first question for you is, was the difficulty of the exam as expected? Yes or no? So I really hope you all participate in this because this will help us to come up with a plan to help you better. And I try to ask questions in the class to sort of get you prepared for what the exam would be like. And so the question is, were you expecting the exam to be as difficult as it was, or was it just catch you completely by surprise?
I didn't.
All right, so getting more responses. Okay, wow. Majority said it was not as expected. Well, in that case, now you know what to expect, right? The first exam is going to be dropped. Okay, so then the next question is, how would you rate the difficulty of the exam? Would it be easy, medium, hard? Okay, so few of you said medium, 2 of you said it's easy. I want to meet the 2 of you. Actually, I don't need to meet the 2 of you. You guys are fine. You don't need my help at all. I'm more interested in talking to the 89 to make sure that how we can bring it from hard to medium. For those of you who feel it's medium, I think you're also doing good enough because I know at least 50 in the class got an 8, but 50% did not get the class average, which was 60. Right? So the range was from 105% to 20%. So it was a pretty large range of distribution. So I have a couple of questions on which part of the exam was more challenging. Right? So was it the multiple choice questions, fill in the blank questions, or do you think both were of similar difficulty? Okay. All right, it's good to know. So the thing is, the multiple choice questions were designed to promote critical thinking, and also were not questions where you could just answer from plain recall memory, which is what the fill in the blanks questions were. So yes, raise the volume up. Is that better? Okay. So the multiple choice questions were more based on critical thinking and where you may have to integrate multiple concepts to answer, to get the correct answer. And so I think moving forward, I'll try to use more multiple choice questions in the review in class so that you can feel better prepared. And then, what do you guys think about the format of the exam? Should we keep it as it is, get rid of multiple choice questions, get rid of fill in the blanks, or do you want me to introduce it true or false questions? So I'll tell you, I'll warn you about true or false questions. It's making your chance of getting it wrong by 50%. But I've had people complain about the true or false questions quite a bit. So I'd like to hear your feedback and then I'll discuss it. Okay, status quo is what the majority wanted. Good to know. And the nice thing is, now that you know what the exam format is like, you should be better prepared for the second exams. And my prediction is that people will do a lot better because they'll know how to prepare. So my word of encouragement to all of you is if the exam did not go as planned, see if maybe you need to put more effort, or maybe you did put in the effort but it was not channeled the right way. Please reach out to us and we can help you make sure that you're channeling your efforts appropriately. So with that, let's get to an overview of the integumentary system, part 2. So we were talking about the various components of the integumentary system. We talked about the various layers, what are the cells in those layers, what do those cells do, what are the appendages, what do they do. But now we'll specifically talk about the function of the integumentary system on the whole. Right? So we'll be talking about its protective function, its role in thermoregulation, its metabolic function, endocrine function. We'll discuss all of those. And then I want to talk about the ability of skin to regenerate itself. You know that the topmost layer of the skin is made up of epithelial tissue, which is capable of regeneration. And so we'll see what is the point beyond which the skin cannot regenerate. And we'll look at different types of injuries, considering either burns or frostbites, and seeing, depending on the severity of the injury, whether or not the skin can regenerate. And after that, we'll talk about a few age-related changes which happen to the skin, and that will also affect its function. And after that, we'll talk about a few examples of pathology and what can go wrong with the skin. And this will help you to appreciate what the proper function is. And I, personally, for me, I just want to have a greater sense of gratitude as we talk about different kinds of diseases, because I know I may not be the superstar model or anything like that, but I just see there's so much for me to be thankful about when I just go through the human body and see that so many things can go wrong, and if I don't suffer many of those diseases, I should be very thankful. So in that regard, we talk about acne, warts, epidermolysis bullosa, which is actually a form of blisters which occur in the skin, and it's linked to the type of cell junctions which can have a dysfunction. And then finally, we'll wrap up with cancers. So I'm not sure how much of the pathology I'll be able to complete today, but I don't want to rush things. If needed, we'll just have a part 3 of the integumentary system. Alright? So with that, you see that the main function of the integumentary system is protection. And I told you that there are 3 types of protection. The first one is that it acts as a chemical barrier. And the reason it acts as a chemical barrier is because the skin has what is known as an acid mantle on it. And this acid mantle is formed both from the secretions from the sebaceous glands, which are near the hair follicles, so that's like an oily substance. And then there is also the sweat, which is being secreted. So both of those would combine and have a covering on the skin which has a low pH, and that can have an antibacterial effect. Secondly, you know that the skin also produces the melanin pigment, and that melanin pigment is going to act as a shield over the nucleus of the keratinocytes and protect it from the ultraviolet radiation. We also see that the skin acts as a physical barrier, and I told you that there are some glycoproteins being secreted by the keratinocytes, which are on the uppermost layer. And you also know that there are tons of keratin filaments. So the combination of the keratin pigments along with the glycoproteins, that's going to give a water-resistant barrier to the outermost part of the skin. And this water-resistant barrier has a twofold effect. It's going to prevent loss of water from the body, so it's going to minimize dehydration and also the fluid loss to a big extent. And secondly, if there were any water-soluble pathogens or substances which can harm you, they cannot get in easily because of this water-resistant barrier. And finally, we see that the skin also acts as a biological barrier because of the immune protection it offers against different kinds of pathogens. So we know that there are immune cells in the epidermis, the uppermost layer, specifically in the stratum spinosum. So think about spine-like projection and dendritic cells, also known as the Langerhans cells. They can act as phagocytes to gobble up pathogens. And if you were to go a little deeper, you know that the epidermis is sitting on areolar connective tissue. And areolar connective tissue has tons of immune cells as well. So we see that it's going to offer immune protection. And I also mentioned defensins in last lecture. That is also secreted in your uppermost layer, stratum corneum. And I didn't specify this, but defensins are actually small polypeptides. They're only, the length is from 18 to 45 amino acids, but they have antimicrobial effects as well. So defensins are proteins secreted by the skin. So now that we have considered protection, we move on to the second function, and that is thermoregulation. So the skin is going to try to maintain the body temperature. And the reason is if your temperature is not maintained optimally, it can affect the functioning of the various proteins in your body. You change the environment, you change the protein structure and its function. So we see that the body temperature can be regulated by both perspiration, which is sensible and insensible. So the insensible perspiration is what happens when you're just sitting around in the classroom or even just going to sleep. You're still losing around half a liter of water per day at room temperature. So if you want to test this out for yourself, weigh yourself before you go to bed, right? And when you wake up in the morning, weigh yourself again. Your weight would have slightly increased. So that's how you can convince yourself that, hey, insensible perspiration actually does happen. And let's say you're out for a run or you're exercising, it's a hot day, we see that the body is going to produce sweat, which can also decrease the temperature. And I want to point out how the skin is going to ensure that it can retain the heat if it's very cold outside, or if it can also dissipate the heat if it's too hot. So what happens is, if you see right here, if it's too cold, the blood is not going to be circulated all the way to the surface, but it's just going to stay in the lower layers of the skin, and therefore the heat is not going to be dissipated. However, if you want the heat to be dissipated and to increase the body temperature, then the blood will be circulated all the way to the surface of the skin. And notice that it's circulated only in the dermis. There's no blood vessels in the epidermis. So the next function of the skin is its cutaneous sensory reception. So we can detect what are the changes going on in the environment. So there are thermoreceptors to detect the changes in temperature, and one example of that is the Raffini corpuscles, which can detect warmth. And also we see there are different types of touch receptors, like Merkel discs right on the epidermis, and then you have the Meissner's corpuscles in the dermis, and we have receptors to detect deep pressure, like the Pacinian corpuscles, and there's also free nerve endings which can detect pain. So if your skin is damaged, then you will not be able to sense what is going on in the environment, and this will make sense when we discuss about the burn injuries. We also know that the skin is responsible for a number of metabolic reactions. And one example is the synthesis of the vitamin D precursor. So if you consider how vitamin D is produced in our body, it can be produced as a result of the food we eat, or it could be as a result of the UV radiations coming from the sun, and that can convert this compound known as 7-dehydroxycholesterol into vitamin D3. So the type of vitamin D precursor from food is vitamin D2, but what we get as a result of the sunlight interacting with our skin is vitamin D3. And I don't need you to learn all these names in black. It's sufficient if you just know the terms that are used. And both vitamin B2 and D3, they can be converted in the liver to a compound known as calcidiol, right? And calcidiol is an inactive form of vitamin D, and that is taken to the kidney and it's converted into calcitriol. And again, it's just sufficient if you know these terms: vitamin B2, B3, calcidiol, and calcitriol, and also know the 7-dehydroxycholesterol, which is the precursor found in the skin. And vitamin D, it will act on your small intestines to help with the absorption of calcium, and this is very important for the bone, which we will be discussing later this week. So in addition to generating this vitamin D precursor, the skin also is known to produce a number of other hormones, including sex hormones, insulin like growth factor 1, IGF-1. I've mentioned its importance when we talk about acne in a few more slides. And it can also lead to low corticoid synthesis. So these hormones, if their secretion or their synthesis is being dysregulated, it can be associated with inflammatory disorders and also with autoimmune diseases as well. We also see that the skin is serving as a reservoir for blood. Actually, 5% of your body's blood reservoir is going to be in the dermis. And depending on the type of need you have, the blood will be shunted to that specific organ as needed. And finally, we see that skin also has an excretory function, because when you sweat, you not only cool down the body temperature, you can also get rid of waste like urea and other unwanted salts. So, having discussed all the functions of the integument, we will talk about injury and repair. Now, repair can happen in a couple of ways. You could have either tissue regeneration, or you could have fibrosis. So tissue regeneration is where you have the damaged tissue being replaced. So if you see in this figure here, the epithelial cells are damaged, but then as a result of regeneration, the epithelial cells are being restored back at the surface of the skin. However, in fibrosis, you have fibrous connective tissue replacing the tissue which was lost. Now, both of these seem to establish the integrity of the skin. It's acting as a barrier. But the problem is that this tissue which has been replaced by connective tissue, it cannot carry out its usual function. For example, if you have fibrosis in your cardiac muscle, then that part of your heart cannot function. So that is the major difference. So we know that different kinds of tissues will have different regenerative capacities. Okay? And we're going to look at how these tissues are classified on a spectrum. So if you were to consider some of the worst tissue capable of regeneration, it's the muscle. So skeletal muscle, cardiac muscle, all of these will regenerate poorly, and also nervous tissue can also regenerate very poorly, and we can discuss why this is the case when we talk about the nervous system. But as far as the cardiac and muscle is concerned, we see that there's fibrous tissue replacing what was lost, and you don't have regeneration. And in the case of cartilage, we know that there's no blood supply, and that's one of the reasons why the tissue cannot regenerate. If you consider tissues which have moderate regenerative capacity, it's the smooth muscle tissue and the dense connective, regular connective tissue. So just one side note about dense connective, regular connective tissue. I'm sure there are many of you who are interested in exercising or maybe athletes. But we know that tendons are made up of the dense regular connective tissue. And so if you have an injury, it's best to allow that tendon to heal, give it a couple of weeks, because they did a study using rats where they injured their tendons, and they wanted to see how much time was optimal to see if those rats could recover completely. And so those rats which had like 2 weeks or more rest, they were able to completely recover function and go back to those exercises. Those other rats which wanted to push through the pain and not listen to their body didn't go so well, right? So you want to make sure that if you're injured, there's wisdom. It takes as much discipline in saying no to that regular schedule and letting your body heal. So this is from personal experience. So moving on to tissue which regenerates the best, bones definitely can heal completely. Epithelial tissue and also this loose areolar connective tissue, which is right below the epidermis, and that makes sense. If you can heal the epithelial tissue and the areolar tissue, that's why even if you have an injury on your skin, if it's not too severe, it can regenerate completely. So when you think about how wound healing happens, there's a pathway for this, and there are 4 steps, and we'll talk about each of these steps in detail. Relatively detail, not too much. So the first step is homeostasis, which happens soon after the injury. And the main goal of this homeostasis is to prevent blood loss. And so you have blood platelets which start aggregating, and we'll talk about these when we discuss blood. But the actual pathway behind how blood starts to clot is super complex, right? So as I said, it's complex, and know that the blood platelets are going to be involved in that. And then the blood vessels will also start constricting to decrease the blood supply to that area where the wound has happened. And you will notice a scab starts forming, and this is because of fibrin, which is also a protein secreted by the fibroblasts found in your areolar connective tissue. And not only is the loss of blood being prevented, but also the next step is initiated, which is the inflammation. So inflammation is an immune reaction. You have lots of white blood cells coming to that area which was injured to prevent an infection. So you have macrophages, like neutrophils, macrophages, they come there and they're going to engage in phagocytosis to gobble up the pathogens that show up, and also they release growth factors because we need to move to the next stage, which is cell proliferation. So notice that inflammation also begins on the same day of the injury, but it's going to persist for a bit longer. And after the inflammation dies out, you have the proliferative stage where you have the different kinds of cells in that area start multiplying. So you have fibroblasts coming there and producing collagen. I'm sure you remember we talked about fibroblasts producing the extracellular matrix when we discussed the connective tissue. So they produce collagen, and then the epidermal cells will start dividing to start forming the outer layer. And you also have blood cells being formed so that the various nutrients can be brought there and waste products can be taken away, and to restore what blood vessels may have been damaged. And in the final stage of remodeling, it can happen maybe in a couple of weeks, and it can last for quite a while depending on the severity of the injury. But the collagen fibers which were put there during the proliferative stage, they're going to be remodeled and arranged around. And I told you that initially there was a scab which was formed by blood drying, but that is going to be replaced with a fibrous tissue to form a scar. And right below the scar, you have the epithelial cells which are also being formed, and they're going to be pushed upwards so that it gives sufficient time that scar can completely disappear. So these are the various steps in how wound healing can take place. But let's talk about what happens in burns. So burns can happen not only because of heat, but it can also be due to electric current or due to radiation or also some types of chemicals. And the main consequence of having such high temperatures is that it's going to denature the proteins which are found in the skin, and that can lead to cell death. Now the immediate problem when you have this type of insult to the skin is that you're going to have blood loss, and if you're losing fluids, you're also going to lose electrolytes, and that can send your body into shock. And so it can lead to a shutdown of your circulatory system, and so that is one of the major concerns of burns. But after this initial risk, what follows next is that because you've exposed the physical barrier, you're exposing the skin to a risk of infections. Now, as you see this figure here, we can classify burns based on which layer of the epidermis, which layer of the integument was affected. Was it just the epidermis, or was it also the dermis, or did it go all the way to the hypodermis? So first degree burn is where only the epidermis is affected, and you will see some redness that may be painful to touch, and the swelling is quite mild. And it is caused by sunburns or maybe quickly touching a stove, and it's either a short exposure to a mild stimulus or a prolonged exposure to a mild stimulus, like exposure to the sun. The way you treat a first degree burn is first you got to decrease the temperature by cooling that area which is affected by keeping it under water. You also want to cover the burn with some type of covering which is not going to stick to it and make your skin come up and you take off the dressing. Oops. And if needed, you can also take pain relievers as well. And the thing is, when it's a first degree burn, you don't need to do much. Within a couple of days, even if you don't take more care than what is mentioned here, it's going to heal eventually. However, in a second degree burn, things are not that simple, because you have not only the epidermis affected, but you also have the dermis being affected. And here you will have greater pain, there will be greater degree of redness, and there can also be blistering or swelling. And the reason for blistering and swelling is that if you were to affect the blood vessels down below and the cells are affected, it's going to cause fluid from those cells to leak into the extracellular area or into the interstitial area, and that's why you have blisters being formed. And this could be it's caused by a longer stimuli, or maybe it's a chemical burn or the short exposure to a more intense stimulus. And the treatment is similar to how you would treat a first degree burn. Cool it in water, you cover it with sterile non-adhesive material. But the important thing here is you want to protect blisters from being broken, because it's very tempting to poke that blister, resist it, because if you were to burst the blister, you are going to open the protective layer, and that can increase the risk of infection. And depending on the severity of even the second degree burn, you want to prevent shock by making the patient either lie down and to elevate the burned area of the heart. You can cover them with a blanket. Now, notice that there are some areas in the body which are extremely sensitive, like the face, the groin area, hands and feet, because it comes in contact with the surfaces. And so if it's those areas and you have a second degree burn which is more than 3 inches in width, then it should be considered as a third degree burn and appropriate steps should be taken. And a third degree burn is where you have all the 3 layers affected, all the way down to the hypodermis is being affected. And we see that skin can be charred, it can be blackened, and it can turn pretty leathery. And this is caused by intense fire, electrical burns, and also prolonged exposure to a moderate stimuli or a short exposure to a strong stimulus. So in terms of treatment, the first step is make sure you call for emergency, because if you're not a trained professional, the first thing to do is ask for professional help. But in the meanwhile, you can cover the injury with a sterile, non-adhesive dressing. And the difference between third degree burn and second degree burn is that you don't want to try to cool it, because it's already now a number of layers have been affected, and so you can increase the risk of infection by trying to apply ointment or by submerging into water. You also want to prevent shock by covering the patient and by lifting the injured area above the heart. And that's about it. So I have a couple of pictures to show you, and maybe you can tell me what type of burn this is based on that. Talk to neighbors if needed. Alright, so what do you guys think? Okay, most people said second degree, alright. And what was the reason for calling a second degree burn? Blisters. Excellent, very good. What about this one? Yeah. Alright, fantastic. Everyone knows the first degree burn because we see there's no blistering and it's usually from exposure to sun. What about this one?
Yes, first.
So if you're thinking about going to med school or not, you should help you decide. Alright, it is a third degree burn, and because we see the skin is charred and blackened. Alright, one more, just one more, right? What about this one? Yep, it is a second degree burn because you see blistering and you don't, the skin isn't broken. So I would say second degree burn. There's one thing I want to mention about the third degree burn picture. I show you that because it's damaged all the way down to the hypodermis, most of the nerve endings are destroyed, and so you don't feel pain in those areas where you've had a third degree burn. But if you have third degree burn in one area, it's most likely that the surrounding areas have a second or first degree burn, so those areas will hurt. So now we move on to the second type of injury, and that is frostbites. And I hope this motivates us all to be nice and bundled up within the next couple of months when it's very necessary. So frostbites are also known as the freezing cold injury, and it can happen whenever you're exposed to temperatures below 0 degrees centigrade. And similar to burn injuries, frostbite also has a staging system depending on which specific layer is going to be affected. So if you look at a first degree frostbite, it's also known as a frost nip. There's going to be numbness in the area where you're affected. There will be pain, tingling, but the important thing is that it's not going to be a long-term damage. In terms of second degree frostbites, you notice that there is this clear colored blisters, which is called milky blisters, and there will be reddening of the skin. That's what we mean by erythema. And also the fluid accumulation is called edema in the surrounding areas. That's because the blood vessels are affected, and so they are leaking out the fluid into the surrounding tissue. In the third degree frostbite, you could have digital edema where you have some parts of the digits being affected, and you can see that it's become red in color. And the blisters, they could be clear or hemorrhagic, meaning they start bleeding and the blisters with blood inside it. And this is the most terminal degree, and this is called fourth degree frostbite, where you see that gangrene sets in, whereas there's like all the tissues are going to die because of the exposure to the cold. And in this situation, the patient had to have all the digits amputated. So the question is, what does the cold temperature do to the skin? So when the temperature drops very dramatically, it's going to cause the fluid inside your cells to start freezing. And that repeated freeze-thaw cycle is going to have those crystals lyse your cells, and that's how the cells start dying. Right? So these are the different kinds of injuries which can happen, and if it's first or second degree injuries, the regenerative capacity is better, but if you were to go deeper than that, it's pretty poor. And even in burns, we can you can have a classification called a fourth degree burn if the bones and muscles are also affected. Any questions up to this point? Okay, there are no questions. Let's talk about some of the age-related changes. So I have a question for all of you. What do you think are ages? Should be able to make some diagnosis based on the picture. Okay. So most of you pick her at 90 to 100 years, and okay. Right, good. What do you think his age is? Oh, wow. 50 to 60. Great. So, I'll tell you what their answers are. This is a 62-year-old Native American woman who lives most of her life outdoors. And this is a 91-year-old Japanese monk who lives most of his life indoors. And we know that most of the damage to the skin is by sun, and that causes rapid aging. And also the moral of the story is majority of you should not engage in gambling because it doesn't seem to work. That's why you're here, to get an education, great. So when we think about what are some of the changes which happen to the skin as we age, we see that firstly there's going to be a thinning of your skin because the stratum basale activity is going to decline as you age. So you see that this is where you have all those mitotically active cells. Their activity is going to decline, and then you see that the connection between the epidermis and the dermis is also going to be weakened. And I told you that this connection is made by epidermal ridges. That's the connection which will be weakened. We also see that the sensitivity to infection is going to increase because the number of dendritic cells, also known as the Langerhans cells, they're also going to decrease as a person ages by 50%. And the thinner your skin, then your hormone has, your skin has less of the 7-dehydroxycholesterol being produced, and so when there is exposure to the sunlight, your skin doesn't produce as much vitamin D. And so for institutionalized elderly people, they have these sun lamps to make sure that they have the vitamin D production. And the melanocyte activity is also going to lower as you get older, and that's the reason why the skin gets paler. We also see that the skin will be a lot drier because the activity of the sebaceous glands is going to decline, and the blood supply is also going to be a lot less, and so you feel cold most of the times. And the hair follicles, they stop the normal function, and so the hair which was usually thick and dark is going to be lighter, and it's also going to become a lot thinner. And the skin is going to get wrinkled because the elastic fibers which were present, they're going to decrease in their size as well. So with that, we'll move on to specific types of pathologies associated with the skin. So we start with acne. And acne is something which is going to affect 85% of the population between the ages of 12 to 25 years of age. And the reason for acne is it's mainly caused by an overproduction of sebum. And sebum is produced by the sebaceous glands. And what triggers the sebum to the sebaceous glands to increase the sebum production is the stimulation of androgens and other related hormones. And we know that when there's a growth spurt and puberty is coming around, there's increased androgen production, and that's why you have increased acne as well. So the sebum which is produced at the sebaceous gland is going to gradually move upward towards the pore, and it's going to carry along some of the dead keratinocytes and the lipids which are produced. And see, this is just a picture of the sebaceous gland. And generally speaking, there's supposed to be desquamation which will happen layer by layer. So desquamation is just referring to the upper layers of the skin being shed. But in some individuals, if the desquamation is not happening at an even rate, then these pores can get plugged. And if the pores are plugged, then below that you have an accumulation of the sebaceous, so the sebum secretion. And it's going to remain white as long as it doesn't come in contact with the air. But then once it does come in contact with the air, it's going to turn black, and that's when it's a blackhead. So how can we prevent acne? Are there any dietary choices we can make? So it was found that when they looked at foods which have a high glycemic index, so what we mean by foods which have a high glycemic index is they're going to cause a spike in your blood glucose level when you eat them. So if you were to drink honey versus eat oats, then your blood sugar level will be a lot lower when you eat oats versus honey. And there's an indication that there may be a trigger between foods which have a high glycemic index and acne. So they looked at milk and they saw that it increased the IGF-1 synthesis, insulin-like growth factor 1 synthesis. And when they saw the chocolates, that was increasing cytokine synthesis. And we know that cytokines will lead to inflammatory responses. And I mentioned this when we talked about the barrier being affected by pathogens coming in when tight junctions are impacted. And this IGF-1 is going to increase the amounts of fats produced by the sebaceous gland. So there's more lipogenesis and you have more sebum being produced. So they were like, okay, what if we change the type of food? And they saw that people who were eating Paleolithic diets, which were rich in high omega-3 fatty acids, they seem to have a lower risk of acne because these omega-3 fatty acids will decrease the inflammatory cytokines. So what if you're not willing to make the dietary choices? Can you take some medicines? Yes. Vitamin A, the form called retinoid, which is a more active form of vitamin A, it's going to be marketed under the name of Accutane. So this is actually the most prescribed drug to treat acne, and it decreases acne by doing three things. It's going to decrease the sebum production, it's going to decrease inflammation, and it's also going to ensure normal desquamation so that the layers are coming off normally. And this is going to be taken orally. But the one problem is that vitamin A in high doses can be extremely toxic, and that's why on the packet they say don't get pregnant, because it can cause birth defects. And the way vitamin A works is it's going to influence gene expression. So in smaller quantities, it's going to ensure that there's going to be proper desquamation of the epithelial cells from the topmost layer. Now, vitamin A can also help people treat their wrinkles, and so it's marketed as Retin-A. And what it does is it's going to affect gene expression, and will have a higher turnover of collagen. And so collagen is what makes your skin form. And this is great for the people marketing it because the effects are temporary, and you need to keep using it regularly. And the problem about birth defects is not an issue when you're trying to get rid of wrinkles, because you're probably not trying to have children at that time. And also notice that the effect of people can also use Botox injections. I'm sure you've heard about that. And Botox mechanism is slightly different. It's going to block the release of acetylcholine, which is a neurotransmitter, and that can trigger muscular contraction. And we'll talk about that mechanism when we discuss the nervous system and the muscular system. But by preventing these facial muscles from contracting, it's going to make the wrinkles seem less pronounced. So this is also a temporary effect, and it would need to we need to continue doing it in order to keep the skin nice and smooth. So let's talk about one more kind of pathology, and that is warts. And these warts, they are the second most common complaint after acne. And the reason warts appear is because the keratinocytes on your skin, they're going to be infected by human papillomavirus. And this virus can cause the skin to have these raised and rough appearances. And the risk of catching this virus is greater, especially if you have open sores coming in contact with the virus. But this is not too deadly. It can be treated with cryotherapy or with surgically it can be removed. So we'll talk about just one more pathology, and that is epidermolysis bullosa. So this is a condition where it's causing the skin to blister easily, and depending on which layer of the skin is being affected, you can appropriately classify it as well. So you have EB simplex, junctional EB, and also dystrophic EB. So we will be applying the concepts we learned in terms of cell junctions when you understand why epidermolysis bullosa can occur. So if you look at this cartoon here, you'll see that there are different things shown in this figure, and I'm going to talk about a few of these. So there can be abnormalities which arise from this part known as the intermediate filament. It's marked here as the tonofilament, which is a type of keratin. And if that filament is problematic, it can cause the simplex type of EB. There can also be a problem with the hemidesmosomes, which anchor the epidermal cells to the extracellular matrix. And you could also have problems in the anchoring fibrils, which is a part of the basement membrane. So I mentioned the basement membrane very briefly when we discussed connective tissue, and there are actually two parts to the basement membrane, which I didn't mention. So one part is known as the lamina lucida, and also the lower part is known as the lamina densa. So in the lamina lucida, you have integrin and laminin, right? So I mentioned these two proteins when we talked about the connective tissues. We talked about integrins and laminins. So I just want you to know that we're applying what we learned previously in today's lecture. And this anchoring junction is going to be, the collagen is going to be below this lamina densa layer. So we see that if it's the problem with the tonofilaments, it's going to cause EB simplex. If it's a problem with the hemidesmosomes, it's going to be junctional EB. And if it's a problem with that layer below that, it's going to lead to dystrophic epidermolysis bullosa. And the problem with this disease is that it can make the skin very sensitive, and it can lead to large ulcerations and blisters if it's junctional EB, and if it's dystrophic EB, it can lead to scarring and thickened skin. And this is a patient with who's got dystrophic EB. So I just will continue with class with this lecture next class. But I wanted to say that these students who have EB, you can't even hold, and even a loving touch can just cause bleeding. And so I know how much it would affect me if I couldn't hold my daughter. So it's giving me definitely a great sense of gratitude. So with that, let's continue with class on Wednesday when I see. We'll talk about the rest of EB consequences as well.
One thing that I've noticed working out when you're talking about how just when you compare certain muscle activities like athletic really helps you. That's really awesome. Thank you so much.
Is there a way that we can see really test like see your answer? Okay.
Hi, I just have Abby. Hi, Abby. Abby's my daughter's name
too.
Oh, seriously?
Yeah.
Good to know.
Yeah.
Well, I just had a few questions that I was hoping to clear up with you. So I didn't understand the difference between the gap junction and so I know the tight junction is different, but the gap and the anchoring are pretty similar. I didn't,
Oh wait. So, gap and anchor.
or is it the tight anchoring? I know two of them were really similar to me.
Yeah, so gap junctions allow cells to have the cytoplasm connected, right? That is gap junctions. Tight junctions are at the apex of the cells. They are towards the apical surface. And so their goal is to prevent things from getting in between cells.
Like viruses and stuff like that.
Viruses, glucose, anything.
Just
right?
liquids.
Huh?
Just liquids and stuff as well.
Anything, yeah. So tight junctions are going to fix the gap between cells, right? Anchoring junctions, their role is to provide mechanical support, right? And they're going to, so if your cells are being pulled against each other, then it's going to provide mechanical support, which is why there are 4 subdivisions. And among those 4 subdivisions, 2 are laterally present, so they are found below the tight junctions. The other 2 they are found between the basal junction, basal cell, part of the cell and the extracellular matrix.
Okay.
Right?
Yeah.
So that's how you classify those 4 into 2 categories. But among those 2, the question is what type of proteins are found in them.
Yeah.
So some have integrins, others have.
Yeah, that was my other question.
Yeah.
I guess the other question was the difference between
Cadherins.
those.
Claudins are for
Yeah.
tight junctions.
And then the cadherins. So, and you said those are both located in the lamina?
Yeah.
And so the lamina, that's just like a part of the top of the skin.
So the laminin is a protein found in the basal lamina.
Oh, it's a protein.
Yeah.
Okay, I didn't get that.
Laminin is a type of protein which is found in the basal lamina.
Okay, thank you.
Yeah. These are, it's because these details are there, it's easy to get mixed up.
Yeah.
It's easy for me to write questions on this. You change one thing and then
The whole thing doesn't make sense.
and you can test it.
Also, what was your office hours? Or do you have
I don't have office hours
Okay.
at this point, but I'm happy to meet students on Zoom.
Okay, so we'll just like reach out.
Yeah.
Okay. Thank you very much.
You're welcome.
I was
What's your name?
Lucas.
Hi, Lucas.
I was just gonna ask if